The next group of drugs are what's deemed the central analgesics. And I think that probably the best case in point to discuss is tramadol, again under the brand name Ultram. It has two mechanisms. First, it's a mu opioid receptor agonist, and so basically it has a lot of similarities to some of the opioids, which we're going to discuss later. And the other mechanism is that it inhibits reuptake of both norepinephrine and serotonin. And so by that way, it's an indirect acting agonist. Okay, and so here's kind of a nice schema of where the locus coeruleus projects and some of the kind of sensory fibers that interact within the substantia gelatinosa. I don't think we can go through this diagram in its entirety because I don't think we've done all of the neuroscience behind it just yet. So I'm gonna stay away from trying to tie in the pathophysiology with the pharmacology, at least in the instance of this lecture. So we're gonna just kind of dwell on that mechanism of reuptake. And so if you remember from adrenergic physiology, here's your norepinephrine secreting neuron. The serotonergic neuron has kind of a similar story. It's obviously a different protein, but we're going to kind of focus here on this NET, this norepinephrine transporter. And basically what it does is it kind of acts very similar to the alpha-2 receptor in terms of its ability to kind of recycle excess norepinephrine that exists within the synapse. And so what tramadol does is it interferes with the ability of this protein to recycle norepinephrine. Okay, and there's another one for serotonin as well. Okay, and so the reuptake essentially is going to recycle and kind of reduce the amount of norepinephrine within the synapse. And so blocking this reuptake process basically leaves the neurotransmitter, either norepinephrine or serotonin, within the synapse for longer periods of time. So if it's in here, if it's in this area for longer periods of time, essentially that means it can bind to these adrenoreceptors down here and other receptors within the CNS. Okay, and so that's kind of the take-home message here. Likewise, it's been shown that the SSRIs, specifically duloxetine, have also been shown to at least reduce back pain in some of these patients through a mechanism that's I don't think completely understood. And other indications for duloxetine specifically include depression and anxiety, of course, but newer kind of pain syndromes like fibromyalgia, diabetic neuropathies, as well as musculoskeletal pain. Okay, and so it is an SSRI, but there also is some crossover. It has effects on norepinephrine, and it also has effects on dopamine as well. So it's not a specific or highly specific SSRI. Of course, the side effects to duloxetine include serotonin syndrome, as well as headache, nausea, and vomiting, and then the black box warning of suicidal ideation, particularly in young patients. Okay, and so this is kind of again, a brief introduction to some of these drugs that have been clinically shown to have some effect in terms of treating patients with pain, and this is kind of our introduction to the CNS pharmacology. So we will end here, and our last video will be on opioids.